So we're going to move into some moderated Q&A, and then we'll open it up to the audience afterwards. Both of you have really troubling experiences, first just getting diagnosed before even having to take these terrible drugs and have those consequences. And I think it's really interesting that, Steve, you're coming from a relatively low incidence setting, kind of like the US, where we might say, okay, people don't normally think of TB when someone is presenting to the hospital in this way. But Vumeza, you're coming from South Africa, which is one of the highest TB burden countries, and you still had to really fight to get a proper diagnosis. And I think both of you have clearly done a great job advocating for yourselves to get diagnosed even in the first place. But I was wondering, since a lot of the people here are also involved in diagnostics development, if you could speak a bit more about, what you would want to see happen in terms of improving diagnosis for TB, since that was the start of your journey and a difficult start at that.
So as I said, at the time, the gene expert machine wasn't available. So the problem now is people are still getting deaf, still getting blind, still taking the same tablets I took back then. So what's really being done with the gene expert? I don't know much about it, but I know that it can detect MDR within a couple of hours, or is it minutes? But still, people go through water intro, so I don't see change here. Really, I don't.
Diagnosis is a funny thing because it's a matter of who you present to, whether they're having an idea that may be TB. So diagnosis is an unusual thing. And we both, well, I certainly live in a country that should be able to come to a conclusion quite quickly. And unluckily, it still doesn't happen. You still have the attitude that it went in the 1950s. With diagnosis, it'd be a great thing if we could just listen maybe more to the patient slightly, just because as we have we have a funny saying where the computer says no. If you are being looked at and the conclusion comes to you haven't got TB, that doesn't mean to say you haven't. I know some people have, some lady that was through 14 years, she was not diagnosed properly because she had pregnancy. They put it down to hormones and all this, that and the other, and she had it in her spine. The other thing is that it can be anywhere, as you know. I had it in my nose, it can be anywhere in your body, and people think it's just a lung thing. So the diagnostics is a long terminology, a long-winded, shall we say, diagnosis. So it's very difficult to come to a conclusion very quickly. And it would just be if you can more listen to the patient at the beginning and try and get, some people aren't symptomatic. So, you do have, TB's not been around for all this time because it's easy to get rid of. We can't hit ourselves. I think you've all been a little bit hard on yourselves when something is only 85% effective, and yet the BCG's never been that effective. So why are we so hard on ourselves at 85% effectiveness? I know we want 95, but we'd love 85% with the BCG. We've never had it. So, let's be fair on ourselves that we're getting there, and we will break it eventually. And I know it doesn't have the funding that HIV had, but if it was easy, we wouldn't all be here working together to get some diagnosis.
So Vumeza, we heard a little bit from you about once you were put on treatment, the challenges with adherence, but I'd like to hear a little bit more from both of you on the challenges that you faced once you were put on standard of care.
You mean with the treatment?
Yes.
So I started to normal TB drugs. They were like 3 tablets a day, which is okay because they told me it would take me 6 months to take. And then when I went to MDR-TB drugs, I thought it was a joke because they put like 20 to 30 tablets, different colors and sizes. So they said I had to take all those tablets right at that moment, all of them. And then after I took them, the nurse was ready with an injection, and then she told me that I would have to take the injection for 6 months. So while I was taking the injection, they had to change size on which palm to prick. So it was really painful, and there were times they had to do it here because it was really painful at the back. So with the drugs, it's not like you're going to take them in the morning and then that's it. They make you sick than you already are. Take those tablets, like 30 minutes later, you're in the bathroom vomiting them. If a nurse follows you, that means bad luck because you have to repeat the tablets. Then if you don't get followed, then, oh, that's great because then you don't have to repeat the tablets. So it's like torture. You just have to look who's watching, and then you go help yourself vomit, and then you come back, then at least you feel better. But then there's 2 years of that. I took them for like 3 years and 8 months, different tablets from MDR, from normal TB, MDR, pre-XDR, XDR. So they changed tablets. So there was a time that we had to like choose with dictation that which tablets I will take. So then I decided to quit the yellow tablets. For those who don't know, the yellow tablets, they're like 3 round tablets. They smell badly, and then those are the ones that make you vomit every day. And also there's a drug, it's yellow too. It's terry something, and then it has suicidal effects. I know people who actually killed themselves in Proclentius Hospital because of the drug, and some with psychosis, and some were hallucinating, seeing things that are not there. So it was really, really bad. And to this day, I think last year, I was at the Union in Liverpool, and there were talks about TB Alliance introducing a 6 months TB regimen. I think that's at least one step ahead, but then I hear that it was under trial because not many patients will get it. They will just choose certain patients. But I think at least that's one step ahead. So there is change, maybe, I don't know, but I'm not impressed.
At the beginning, when I was on the normal regime, I was told if my wee became orange, it would be working. And of course, when you suddenly have orange wee, you think, oh, fantastic, I'm going to be better. It was just downhill from then on. Then, we went on to 20-odd tablets a day, and you're monitored, and you feel forced. Yes, you get very depressed. The whole regime was more suck it than see, or I felt that there was no information about what it was going to do to you, why you were taking it, why so many different tablets were being given to you. Thankfully, I'm probably, a person that has reacted in a particular way, and hopefully others don't. But when we go through these different regimes, it's very good to monitor it as much as you can. This is where the ethambutol done me, because I was monitored every 2 weeks, and then it is extended to the 4 weeks. Well, in between then, I lost my sight. And the deafness also is the other thing. I was constantly being monitored once I took streptomycin to be, is your hearing changed? And I think the monitoring is very important of any drugs that you're given, and information, because I know it can sort of frighten you maybe into a certain extent, but I think more knowledge of your medical. I mean, I would never have read the leaflet because I wasn't well enough. So, it's fine to give these drugs out, but it's much more important to describe what side effects you might get from them, and if you do, to mention them. The one good thing in the UK is that after all the advocate work that we've done, you now get a TB nurse, so-called, and that now monitors you, and you have a first line, like Macmillan nurses in cancer and things like that. You have a first point of call that you can call if you feel ill or if you have any questions. And I think that's something that we've done, which is good.
Again, for both of you, now that you've gone from patient to survivor to really active advocates, have you seen progress in the field, either in diagnosis or in treatment, that's encouraging to you?
Well, I don't want to be negative here, like the bad person always talk bad about people. But as I've said, with the gene expert machine, at least now people get diagnosed. I waited for weeks to get proper diagnosis, which is even years, because they found out later that I actually had XDR from the start, so that meant I took the wrong medication. So at least now I saw something again at the Union. There were blood tests, I think, and also they were checking people with latent TB, and people were also getting medication if they have latent TB. So again, I'm not impressed, but I think you guys can work more with patients rather than, I know there are things that are called patient-centered care, but then you talk about those things and then you don't actually involve the patients or the survivors with decision-making. With the Gen Expect, I'm 50-50 because at least it helps some, it doesn't help some, so it's not really 100%. But I really think it's okay, I guess.
And just to follow up for you, Fumeza, before Steve answers, I mean, part of what to me is so tragic about your story is that you never got a chance to have, it sounds like you didn't get hearing testing and you never got a chance to have bedaquiline when actually Janssen was making it available under compassionate use. So how do you feel now that South Africa is rolling out bedaquiline, but maybe other drugs like delaminid are still not available there?
Okay, I think that's great because I know a doctor, Dr. Dallin for Delft, and I think we got sick at the same time, and she was lucky to get the drug from Janssen, I think. So, and I was there waiting, and they were telling me that I might die. So now that people are actually getting a chance to get this drug, I think it's great. I'm not sure about if it's available to everyone, which is also under patent laws, which meant that the drug companies make it expensive. Is it that way?
Well, the South African program has negotiated with Janssen to make it available to a large
Available
portion.
as in free or available as in cheaper?
Well, the government is paying for it. It's cheaper. It's cheaper than linazolid. I think it's about 900 a course, Tina, in South Africa. Sorry to put you on the spot. I think it's 900 a course in South Africa.
Okay, I think that's great.
Steve?
I don't like to be negative at all. I think, you know, we've got to understand that if it was easy to have sorted out TB, it would have done so by now. I was in the UK when we had the Tombstone advert saying that we'd all die from HIV and Ebola and swine flu, and et cetera, et cetera. So we've had a real big thing. If TB's been going since the beginning of time, so it seems, it would have been cured if we could have done. So that, you know, we mustn't beat ourselves up. Really on that. It's something that this has got us all together, so that's a big positive, isn't it? And we're all talking and we're all sharing. Obviously, you know, there is a lot of costs involved, and that's always one thing. I work for the British HIV Association in UK, and we've just written the new TB guidelines, so they now present them to NICE, which is the organisation that gives drugs out to patients. The trouble is we do have a cost involvement where the FDA seems to not involve costs so much here. We do have a £40,000 cut-off point. So if the drug is over 40 grand for the NHS and it's not over beneficial, it's not available. So, you know, the UK is probably slightly different to here. But I want to be positive and say that I think without all of your efforts, correlation and everybody here trying to talk together, then we'd be a lot worse off. You're still giving the same regime, and I understand the negativity there. You keep relying on that as a backup. Well, now that we have the drug resistance coming through, it might not be there that much longer. So let's try and eradicate it as much as possible, as well as we have done with HIV.
So Steve, you've just mentioned we are all here and we are all sharing over the course of these 4 days, and you have an audience filled with drug developers and scientists and researchers working in this space. We have the regulators here. We have the diagnostics teams here as well. What would you like us to consider as a person living with TB in our daily work or in the goals that we set for our work here at CPTR?
I see a lot, because I do peer supporting, I see a lot of family breakup, debt, maybe even losing their home over TB. The biggest trouble is it can be the sole breadwinner, and really it's supporting the patient, which I find is lacking. It's probably slightly different in the US, and we have a situation where it's not classed as a, you know, a bad, TB is not classed as a bad illness that you're not going to be able to work, etc., etc. But when you take these 20 tablets, all you want to do is sleep or vomit or whatever. So it's a very difficult scenario in the UK, probably. But at least here, we have got everybody together. We don't have a lot of money to do it with. But the one good thing is that we are all collaborating, and that's something that I've never seen before. And that's what has brought me all the way over here, even with Nicole, to say, well, I can't thank you enough to everybody to collaborate together. It's so hard because profits are, you know, important, and getting the regime correct is important. So I can only say, from a patient point of view, thank you very much. But please think of the family and the whole stigma of TB. So I have so many people say to me, can't the doctor say I've got HIV instead? I mean, people want to be HIV positive more than they do TB. That, to me, is bizarre. And that's where the stigma of TB has got to be eliminated as much as possible. Thank you.
I already told them they are news.
We'll open it up to questions and comments from the audience.
Please, to the microphone. Introduce yourself, please.
Not too many at once now.
Thank you so much. It was really very enlightening listening to your experiences. I have two questions for you two. One is DOT, and the other is DTM. Now, DOT, you already know what that means. Do you think that supervising patients in that way means we don't trust them? Should we trust them to take their own drugs? And that's where the DTM comes in, because I'm involved in clinical trials of TB drugs, where we have to make sure that the patients are taking their drugs. Now, clearly, we can't bring them to the clinic every day, so we appoint a DTM, a domiciliary treatment monitor, where we appoint somebody near the patient who can supervise the patient. I think it's a way to get the family involved in the treatment of the patient. Some people say, no, it breaks up the family. And also, I think it perhaps removes the stigma of having TB as well by getting people involved in it. I'd like to hear what you think.
So I didn't hear quite clearly because there was a sound. Just to clear something, you talk about DOTS. We call them DOTS, like daily observed treatment, whereby you get watched to take your medication.
Yes.
Okay. I think that's unfair, for instance, because I don't know any other disease that people get watched to take their medication. Why TB is that? Like, for instance, as I've said, sometimes you're not feeling well to take your medication at the time that they tell you to take your medication. So I think that it is unfair because as patients, you are treated unfairly. As I've said, you are treated as some sort of object, and then there's no respect to the person who's giving you the tablets. So they are just telling you, actually forcing you to take the tablets. And then if you vomit, they will shout at you, how dare you vomit your tablets? Do you see? And then there's stigma attached to TB, even in the healthcare system, whereby the nurses look down on patients, calling them suspects. We are not criminals. We are there because we are sick. So we are people to be evaluated for TB. I'm not sure if I've answered.
In my view, the DOT side of it is usually, in the UK, it's usually where someone has failed their regime. So therefore, the DOT is there to make sure they take it. And I know a 26-year-old lad who's had TB 3 times because he's stopped taking his medication and is now on to advanced drug resistance. And DOT makes a big sense. Where you are at DTM is you're probably not forcing 24 tablets down someone's neck. So you're on a regime that is probably a few tablets, and you're there to make sure that you're taking that for a progression in TB research. And I agree with that wholeheartedly. The reason I think that DOT and DOT is hard is because that most of the time when you do take those 24 tablets, you're zonked out, you're sick, and you feel like rubbish. So it's very hard to be full. If I made you force feed something you didn't eat normally, you wouldn't like it. And that's exactly what happens. So DOT has its moments. It's just that obviously you're trying to keep someone well, and we've tried in the UK where we do it via Skype. We've tried it all sorts of ways, and it isn't sorted unless someone is standing there and does it. But if you are taking on DOT, that's different. But your regime where you're taking it for new drugs, you've got to be present to make sure that the results coming out of it are accurate. So I don't disagree with that, personally.
Hi, Grania Brigden from the Union. Thank you very much for your really powerful talks today, and I think for highlighting that the challenges that are experienced by people with TB and their treatment are the same globally, and there is not the situation where there is one treatment that we're offering that is better, but in fact we need the treatments we've got, both for drug-resistant and TB and drug-sensitive TB, have considerable toxic effects that are life-changing for people on treatment. I just wanted to ask, in your roles as kind of global TB advocates and sort of looking at the people we have in the room who are all very passionate about TB and the need for more investment, more R&D, how can we work together to raise the profile of the challenges we face in TB with global decision makers? It's a big question, I know, but...
Okay, I probably have a very unusual thing about this, but every charity or a company has a logo or something that people remember. HIV stigma disappeared once it was celebritized, shall we say, with Leal and John and all sorts of people supporting HIV. Now, this has never happened to TB, and it kept the stigma going, and everybody thinks that TB went in, you know, the 1900s, etc., etc. And this is the trouble, you know, everybody, even like guide dogs, have a little puppy, Labrador, you know, for breast cancer we have a flower and things like that. So people remember something about it that takes the stigma away. TB has never had, in the UK certainly, and I don't know about here, but it's never had anything to recognise it to. We now have TB Day, which is the day after my birthday, on the 24th of March. It's like World AIDS Day, but there's no real, I don't know, it's still not recognised as something that is still prevalent, still very, very intense in the world today. I'm not being funny, but I'm, you know, from the UK, a white person. They never thought I'd have TB. I was on the tube for 40 years, being blown at by, you know, thousands of people because I worked in London every day. So where did I catch TB? I was told I didn't have TB by the Australian authorities a year before I went there. So the whole thing is so hard. We haven't, you know, we're not here because it's easy. It's a matter of we've got to try and get some sort of stigma repellent, even if it is a celebrity or if it's, you know, a cuddly dog or something that will recognise TB to be accepted. And that's something, as an advocate, I would like to see, but I don't think in my lifetime maybe it will be. I mean, I would say that, and I'm being open with you all here, I lost my sight, as you know, and I lost the will to live. And I have tried to get rid of myself a few times. That's how bad TB has affected me, because I have no self-respect, I have no independence, and I need help all the time. That has crucified me. I'm a 53-year-old man who has no prospects any further. Now, that may sound heavy, but that's my experience and my journey. So that's what I want to explain. We need to get TB destigmatized as soon as we can, really.
Well, for one, TB is the most neglected disease in the world. In case you don't know, it is the leading cause of death now in the world. And I'm not sure is it because TB affects most of the poor that people are not really paying attention to it. Like, for instance, with HIV, we have lots of HIV activists out there. People march the street of South Africa demanding on what's right. Whereas when it comes to TB, there's so little of us. People don't want to come out and talk about TB because of stigma that Steve mentioned. TB, it's been it's been said that it's not sex, it's like that disease that's like there, just keep it shushed there. So I'm not sure what's really happening with the world. It's the leading cause of death. And in this meeting, I didn't hear anyone mention anything about the World TB Day that is like in this week. I think one of the reasons, because, I don't know, maybe we are here because we care, I know, but why didn't we mention it? So, yeah.
Good morning. Thank you both so much for coming. My name's Dan Everett. I'm with the TB Alliance, and I work with developing and overseeing clinical trials for new drug regimens. I'm just curious if you have any recommendations about how we and the doctors and nurses at the sites can do a better job of communicating to patients considering participating in a trial about the risks and side effects of drugs. You've had a lot of experience. I don't know if you've had a chance to review and comment on informed consent documents. They're typically 20 or 30 pages, trying to communicate everything about perhaps the 8 different drugs that might be, you know, patients might get randomized to, but we do rely on the doctors and nurses to discuss it with patients. If you just have any general recommendations of how to do the best job so people really understand what they're getting into.
Personally, it is difficult, as it is with counselling with HIV. People who are diagnosed are normally counselled. To get people involved in drug trials is hard for anything, and I think with the side effects of TB, if you're doing it on people who have TB, I don't know how you do your drug trials. They've got to be aware of the side effects of what they might get. As I say, my family that visited me in a positive pressure room under mask conditions, when they went to Europe, when they went back to Spain, they were given isoniazid immediately. There was no question. So what I'm saying is that, and they had leg issues immediately. So it's not something that is quite uncommon. So if you explain that if this is the regime we have now, and the alternative is to go on to this drug trial, I don't think there's many options, really. I mean, you're going to be as tested as it was in the 1950s. I mean, streptomycin, if this latent TB thing is big in the UK, we now test before people come to the country in high prevalence countries. We got £11 million from the government recently to test people for latent TB, which we never did before. Which is fine, but would you take drugs that could lose your hearing or your sight or give you no nerves in your legs so you can't walk? I mean, you know, the options aren't particularly savoury. So I really think that as long as you're honest, open, and you do the same sort of counselling that you do with HIV, I think, you know, you've got a win-win situation, because the person is so ill. And with TB, I was just out of it. I took, like this lady took 3.5 years. Mine was 2.5 years. And I can quite honestly say for 2 years, I didn't get off the floor. So that was, you know, that was my life. And that was how my partner had to live with me. And he's not a natural carer. So it's like, well, you get up and do something. And that's the only reason I'm here. Because otherwise, I would have taken all the drugs just to get rid of myself. And I did try a few times, I'll tell you. So that's the situation, is that the regime that is offered hasn't got a lot of greats going for it. So if you've got new things coming along, you can put them on a positive slant, and they may take a placebo, so they'll never actually take the drug. So I think you're on a win-win, really.
So, for instance, I get invited to support group that is hosted by Doctors Without Borders in South Africa. So they told me that I must tell the patients what they must expect on TB tablets, but I think that's wrong. That's not my job. It's nurse's job to tell the patient that they might get deaf, they might get blind, they might get this. So sometimes they say I'm there to freak out the patients because they get scared, and it's really hard to raise awareness whereby the nurses don't even want to talk about it. They tell you what to expect with the injection or with the drugs, or whether you're going to vomit, or whether you're going to make it, or whether you're going to be blind. You just take the tablets not knowing what will happen to you. So I think we need to raise awareness on this disease.
Thank you both for sharing your stories and your candor and your emotions that you had to go through to get here. And thanks to the audience for listening and for asking such interesting questions. I think Fumeza and Steve will be here all day, so I encourage everybody to get a chance to speak with them afterwards personally. And we'll close. Oh.
And Nico likes a cuddle, so please, just as long as he's not walking me, please say hello and give him a cuddle. So.
Okay, thank you guys. We'll take a break now.